Hello and welcome to this 4C module on glycemic control in intensive care unit. As you all know, this has become a very hot topic in intensive care, and this is something which we have to practice on a daily basis. So, the objective of this module would be to give you the incidence and practical management tips of managing hyperglycemia in ICU, and to identify and manage the different glycemic emergencies like diabetic ketoacidosis, hyperglycemic hyperosmolar non-ketotic diabetic coma, and hypoglycemias. Let's start with a case. A 45-year-old male patient with cough, breathlessness, dizziness and fever for the past 5 days. He was hypoxemic, saturation 88% on non-rebreathing face mask, was hypotensive, so clearly in shock with blood pressure 82/34 after 2 liters of IV fluid. He was intubated and started on mechanical ventilation. So, how do we initially resuscitate? Yes, we should all do the ABC for this patient, airway, breathing and circulation, but we should not forget to check the capillary blood sugar of this patient as a part of initial resuscitation, because it is imperative that his sugar needs to be controlled. If he is hypoglycemic, that needs to be corrected. So, as a part of initial resuscitation, point of care capillary blood sugar, it was checked on this patient, which came out to be 350 milligram, which was clearly hyperglycemic. There has been a debate whether point of care capillary blood sugars are as accurate as the lab blood sugars through venous or arterial blood samples, but they take a long time for turnaround time. So, capillary blood sugar are still the point of care test for hyperglycemia management. So, what is the pathogenesis? Why is this patient hyperglycemic? He is not a known diabetic. So, why his blood sugar has gone up? What is the pathogenesis in critical illness of hyperglycemia? It is not increased glycogenesis, but there is increased glycogenolysis during stress. There is definitely increased neoglucogenesis. There is increased lipolysis, and there is decreased insulin sensitivity during critical illness. As depicted in this diagram, initially the hyperglycemia happens because of many reasons. First of all, there are certain tissues in the body who are completely dependent on glucose, and which is an insulin independent mechanism, like RBCs, brain and renal tubules. So, body requires, the brain and the RBCs require glucose for maintenance. Now, in order to maintain glucose in the body, there is breakdown of fat cells into fatty acid and glycerol. Glycerol goes into the liver and is converted into glucose and comes back to maintain hyperglycemia in the critical ill patient, because of the macroendocrine and microendocrine responses, increased cortisol, increased thyroxine, increased catecholamines and increased cytokines. These changes take place. At the same time, there is a muscle breakdown. There is a muscle breakdown causing glutamine and alanine in the circulation, of which the glutamine goes, as it is a fuel to enterocytes, it goes inside the intestinal cells, where the alanine takes part into the neoglucogenesis and is converted again in the glucose in order to maintain the glucose pool in the peripheral blood. Similarly, lot of injured tissues will generate lactate because of anaerobic metabolism. This anaerobic metabolism, this lactate again going through the liver is converted into glucose. So, there are many ways by which hyperglycemia is persistent and maintained in the critically ill patient, and that is the reason in this patient, because of increased lipolysis, increased muscle lysis and increased tissue lysis, there is increased production of glucose, and that is why our patient was hyperglycemic. Now, what is the incidence of hyperglycemia into day-to-day care of ICU patient? It differs upon whether it is a medical ICU, surgical ICU, trauma, neuro ICU. So, a study was done in a medical ICU population to know the risk factors and the incidence of hyperglycemia, and this is usually the common picture. Almost 60 to 70% of our patients have blood sugars above 120 when on admission, and about 10 or 11% of them are diabetic. Probably the incidence is somewhat more in our country because of background risk of diabetes and high incidence of diabetes in the community. So, there is a high incidence of hyperglycemia on admission to the intensive care unit. This study done in Mayo Clinics, which shows the association between hyperglycemia and the mortality. As the blood sugar goes up, the incidence, the mortality goes up. This was done by Krinsley, who has done many other studies and showing the same phenomenon. So, hyperglycemia is bad in ICU. It might be a surrogate marker of underlying severity of illness, and so there is more stress response and so more hyperglycemia. The question comes whether reducing this hyperglycemia to normoglycemia decreases mortality or not. How do we assess the glycemic risk? If I have a patient, how do I know whether he is more at risk of getting hyperglycemia, so needs to be more closely monitored for his blood sugars? First, definitely a history of diabetes, comorbidities like obesity, hypertension, metabolic syndrome. These patients are very prone to hyperglycemia. A lot of medications like corticosteroids, even catecholamines, dextrose infusions, total parenteral nutritions, octreotide that we give to these patients, they can have hyperglycemia. And sickness, severity of illness, the more severely ill a patient is, the more is the stress response and the more is the hyperglycemia. So, once we make sure that this patient is hyperglycemic and we document the hyperglycemia, we assess the risk of hyperglycemia in this patient. The next step would be to decide how frequently we need to monitor the blood glucose in these patients. Now, the frequency of measurement will depend upon sickness of the patient. Initially, unstable patient or patient on IV insulin infusion, the blood sugar should be measured every hourly. And if the nursing staffs are not that much, we can at least go to 2 hourly, because there will be high incidence of hypoglycemia, especially at night, if you do not monitor the blood sugars very carefully on patients on insulin infusion and patients who are hemodynamically stable. In patients who are less sick or patients who are on subcutaneous insulin, sugar can be measured every 4 to 6 hourly in these patients. And if there is any change in patient's nutritional status or nutritional delivery regime, we need to modify the frequency of glucose measurement. For example, if somebody is on a TPN and he is on an insulin infusion or subcut insulin, and we have suddenly stopped the TPN for certain procedure, then this patient might suddenly go hypoglycemic, and so we have to do it more frequently. On the other hand, if we increase the enteral nutrition dose, again there is a high chance of hyperglycemia and we have to monitor it very closely. So, depending upon the nutritional delivery regime, we have to modify our frequency of glucose measurements. Now, once I decide on how do I give the insulin, how do I decide on the frequency of blood sugar measurement, then we decide on the target blood sugar. What should be the target I should aim for? Now, different guidelines have been given. As per ADA guideline, the target is around 140 to 180 milligram per dl. In medical ICU patient, different ICU patients like surgical ICU patient with diabetics might have a different target, but by and large, this is what we should aim for, 140 to 180 milligram per dl. Now, the concept of hyperglycemia control in ICU was first generated by Dr. Greet Vanderberg, who have done seminal research on this field. She was the one who first showed in a surgical intensive care unit that tight control of blood sugar between 80 to 120 milligram per dl leads to decreased mortality in this group of patients. She repeated her research in a medical ICU patient, was not able to replicate the same phenomenon in medical ICU patient as a whole, But in a subgroup of medical ICU patient who stayed in ICU for more than 3 days, she was able to show that there is decreased morbidity and mortality in these patients. So, in her unit, in her hands, it was a single center study. Tight glucose control 80 to 120 was definitely helpful in surgical patients and helpful in medical patients who stayed for more than 3 days. So, that is Leuven-1 study, that is the surgical study. Leuven-2 study is the medical study. But after that, a few other studies which are multi-center studies and which kind of gave us a real life practice of blood sugar measurements and control. The GluControl study, which included around 1100 patients. It was done in general mixed medical surgical ICU in an intensive glucose control arm 80 to 110, conventional arm 140 to 180. The intensive glucose arm had reached a blood sugar, mean blood sugar of 118, whereas the conventional arm was 144. And they didn't find any difference between the conventional arm and the intervention arm. The biggest study done in this field was the ANZIC study, the NICE sugar study, which included 6,000 patients. It was a randomized controlled study, multi-center study in a general mixed medical surgical ICU, which randomized patient into an intensive glucose control of 80 to 108 and a conventional sugar control of 144 to 180. In their intensive glucose control arm, they reached a sugar value of 118 versus 145 in the conventional arm. Their endpoint was death at 90 days. They had a mortality of 27.5 in intensive glucose control and 24.9 in conventional glucose. So, they showed that there was no change. If anything, there might be a trend towards harm with tight glucose control. And since then, this concept of tight glucose control between 80 to 110 has gradually gone out of vogue. So, in general medical surgical ICU, probably tight glucose control might not be that helpful. Now, since there were 5 big trials, a meta-analysis was called for. So, a meta-analysis of other trials including glucose control, 26 trial, 13,567 patients. The overall mortality was 0.93, medical was 1, surgical 0.63. So, again it looks like probably a surgical patients are better off with tighter blood sugar control as opposed to their medical counterpart, could be due to various comorbidities, high risk of hypoglycemia in these patients. The incidence of hypoglycemia was high, was 6% in patients having tight blood glucose control. So, American Diabetic Association gave this consensus statement that insulin trigger, that is the blood sugar level above which we should be starting insulin in our ICU is 180 milligram, and we should be controlling sugar between 140 to 180 milligrams. So, once we have decided on the target values, then we have to know how do we give this insulin. By and large, an insulin protocol has to be followed in an intensive care unit. Blood sugar, in an insulin protocol, blood sugar is performed more frequently. Insulin doses are changed more frequently. Insulin doses vary with the rate of change. This is the right one, because in a insulin protocol, in a dynamic insulin protocol, as the sugar values change, one has to change the insulin levels, and hypoglycemia is less frequent if you follow a protocol. So, how do we use insulin? Intravenous infusion of regular insulin is the treatment of choice in critically ill patient. The following group of patients may be candidates for periodic subcutaneous insulin, step down therapy for IV insulin, and less sick patients on oral diet. So, how do we decide on insulin delivery protocol? Every unit should have an insulin delivery protocol. Like this protocol, which is a modified Yale protocol, this is a dynamic insulin protocol. You see the sliding scale insulin, which is very normally performed in most of the units. It's a very static insulin protocol in the sense that a sugar value is given and an insulin is specified, and it goes into only one direction, that is vertically. Now, say in this example, if we have to keep a sugar value of say 180, and first of all I have to choose a scale of insulin in which we start this patient on insulin infusion depending upon the patient's first blood sugar. If the patient's first blood sugar is very high, probably he needs to be started on scale 3 or 4, whereas in renal failure patient and patients whose blood sugars are not very high can have scale 1 or 2. Once we start the patient on that insulin infusion, say if the blood sugar, if I decide on scale 2 and the blood sugar is 220, I start on 4 IV international units per hour of intravenous rapid acting insulin. Now, if my target is 180, my next blood sugar comes as 200. That means I have to go up on the scale, because in the same scale I have to go up on the row, and because in 141 to 200 I have to give 2 units per hour of insulin infusion. On the other hand, if the next sugar value comes to say 250, then I go horizontally, and because it is still between 201 to 250, and give him 6 units per hour. So, depending upon the blood sugar values, I can go either up or I can go horizontally if they are in the range of that column, or go up and down if they are above and beyond that range. So, this is what is called a dynamic insulin infusion protocol. First and foremost, we have to avoid hypoglycemia, which is the biggest problem, and that causes the high mortality in intensive glucose control arm in most of the studies. By definition, blood glucose less than 70 is called hypoglycemia. Despite the acknowledgement of the importance of tight glycemic control in the ICU, a common clinical problem is how to achieve and maintain glucose control without episodes of hypoglycemia, and that is what is the main challenge now. It has been shown by Greta Vandenberg that tight glucose control definitely helps the surgical patient, but in medical patient they are not that useful because of the problem of hypoglycemia. Now, if I can control my hypoglycemia, then probably a tighter sugar control might give us some benefit. A single episode of severe hypoglycemia increases the risk of mortality. So, hypoglycemia and severe hypoglycemia needs to be avoided. These are the different hypoglycemic episodes in the different studies. The first Vandenberg study, the surgical study, it was 5.1%. The medical study, it was 18.7%, biceps 17.6, glucontrol 9.8. Who are the patients at risk for hypoglycemia? Definitely patient with renal failure, patient on dialysis, they can go to sudden severe hypoglycemia. Patient with liver failure due to decreased glycogen reserve. Severely malnourished patients are again at very high risk of hypoglycemia. Patient with adrenal insufficiency or patient who had steroid withdrawal can give rise to sudden hypoglycemia. And in fact, in some patient with a history of steroid use in the past due to various reasons, if they are hypoglycemic in the ICU, the chances are very high they have adrenal insufficiency and require replacement of steroids. Patients who are very sick, not only they can become hyperglycemic, but they can also become severely hypoglycemic. Sometimes it is due to adrenal crisis. They can go into adrenal hemorrhage and there can be severe adrenal insufficiency. How do we manage hypoglycemia? First and foremost, we should stop insulin infusion immediately and give 50 cc of 25% dextrose IV and repeat this till blood glucose is more than 90. And we should be checking blood sugar every 15 minutes. So, this is the second matrix of glucose control. First is avoid hyperglycemia, second is avoid hypoglycemia, third is avoid large variation in glucose control in ICU. This is the third domain of sugar control. Again, some phenomenal work done by Professor Krinsley, who had shown that if the blood sugar varies in the ICU, these are the different quartiles of the blood sugar values. The more is the quartile, the more is the variability, the mortality increases. So, the mortality increases if there is more and more variation in the blood sugar level. And the highest mortality will be in patients who have, you see the variability is higher in patients who have a blood sugar between 140 to 180 range, and they have the highest mortality. Even a blood sugar in the normal range, within the recommended range of 140 to 180, if the variability increases, the mortality increases. We should avoid undertreatment, avoid hyperglycemia, and avoid overtreatment, and consider safety issue. Ultimately, the sugar control is a multidisciplinary task. We need to follow an insulin protocol. There has to be different members of the team needs to participate, which include anesthesia, surgery, nursing, healthcare quality. This is a quality control issue, pharmacy, and our diabetic specialists. And we need to check our systems. Now, once we have done the initial sugar control, the patient is better. Now, this patient needs to be discharged to the ward. Then what should be my protocol? We can't send him to the ward with an insulin infusion. So we change to intermittent treatment before discharge. We switch over to subcutaneous insulin. We use a sliding scale with short-acting insulin along with long-acting insulin, like we normally manage a chronic diabetics. So long-acting insulin should overlap insulin infusion to prevent hyperglycemia. So you give one dose of a long-acting insulin and then continue infusion for a couple of hours after that and then stop. And the dosage of pre-meals, short-acting and the long-acting insulin has to be taken into account depending upon the patient's daily requirement of insulin infusion initially, history of diabetes, the type of diabetes, steroid use, and overall clinical status of the patient. So this was the general blood sugar control of these patients in the ICU. Now let's talk about a few diabetic emergencies. A 25-year-old type 1 diabetic with a venous pH of 7.26, severely acidotic with a glucose of 290, bicarb of 16, anion gap of 16, and positive urine ketones. A second patient, 51, a slightly older patient, no chronic illness, comes with a sodium of 141, chloride 98, bicarb 13, glucose 1000/640, BUN 70, urine ketones are moderate. So what is case A? Clearly this is a case of diabetic ketoacidosis, younger group of patient, severely acidotic, glucose level is not that high, and severely acidotic with positive urine ketones. On the other hand, hyperglycemic hyperosmolar syndrome is seen in relatively elderly patients who are usually not insulin dependent, and they have a renal insufficiency that pushes the blood sugars very high. They get very dehydrated and they get acidotic, not to that extent as the diabetic ketoacidosis, and they can have urine ketones which can be due to starvation ketosis, and it can be moderate, and they have a very high osmolality. So the first thing is to calculate the serum osmolality, which is done by a formula which include the sodium, the glucose, the blood urea, nitrogen, and by and large the serum osmolalities are usually high. These are the calculated osmolalities. If one have access to measure osmolality, even that will remain very high in these two group of patients, much higher in hyperosmolar state. So first and foremost, just like we do with every patient in intensive care unit, we should initially resuscitate these patients. They are severely dehydrated, so they require fluid. We should urgently insert 2 wide bore intravenous cannulae in these patients, place central line if and only when necessary. If we can't get an access because of complete failure of collapse of veins, if patient requires vasopressors, if they are in severe shock, because they might have an underlying sepsis, can go into septic shock, and if they have a bad heart or bad kidneys, we are not very sure about their volume status, and patient with severe acidosis. These patients all require central lines. We should estimate, have some idea about the severity of dehydration by looking at the orthostasis, the pulse, the tachycardia in sitting posture. We should look at the sodium. Usually severely dehydrated patients have a very high sodium which needs to be corrected for glucose. They will have a very high urea and creatinine. Most of the time this is pre-renal, but in an hyperosmolar state it can also be renal. The average fluid loss in diabetic ketoacidosis and hyperosmolar state is 3 to 6 liters in DKA and 8 to 10 liters in HHS. So the dehydration has to be corrected along with hemodynamic stability, with usually initially with normal saline, even in hypernatremic patient, because for an hypernatremic patient normal saline will be hypoosmolar, because if the sodium is, say for example 160, normal saline will still be hypotonic. The patient should get 15 to 20 cc per kg in the first hour, so it comes to around a liter or 2, and then around 50 to 200 cc per hour till hypovolemia is corrected. After giving about couple of liters of normal saline over an hour or two, we should again evaluate serum sodium, which will give us some idea about the state of dehydration and correct the serum sodium for glucose value. And then we can switch to a balanced solution containing less chloride, which will give rise to less hyperchloremic acidosis. And in hyperosmolar state, especially because of renal failure problem, we should be using solutions with less chloride. Once the blood sugar comes down to 250 to 350, we should give fluids which have got dextrose in it, like dextrose saline. The reason for that is we don't want a severe fluctuations of blood sugar. This is mainly applicable to critically ill children where there is cerebral edema. If there is a sudden shift of blood sugar between, say, from 800 to 200, and the kids can get seizure. But this is also applicable to elderly diabetics as well and in hyperosmolar state. So once it comes down to 250 to 350, we should not be lowering it too drastic, and if necessary give some glucose. We should maintain a urine output of 1 to 3 cc's per kg per hour, so around 50 to 100 cc's per hour. But we have to ensure that the urine doesn't have any glucose. So once the patient is not glycosuric, then maintaining this urine output usually means that we are correcting the dehydration, and we have to replace the urinary loss through intravenous fluid and also give the maintenance fluid. We should definitely take a very focused history, physical examination, and essential investigation in patients with hyperglycemic, hyperosmolar state and DKA. We should take a detailed history about their medication use, insulin and oral drugs. Many of times these conditions are precipitated due to an infection. So we have to identify any source of sepsis. We have to send a battery of investigations which include sodium, potassium, phosphate, calcium, magnesium, renal status by BUN, creatinine, acid-base balance by bicarbonate, blood gases, osmolar state by plasma osmolality. Sometimes they have a high, falsely high amylase lipase without having an anatomical pancreatitis. So it is more of a biochemical pancreatitis. We should also look at the urine for pus cells and protein and glucose and do a blood count. There is almost always a leukocytosis in these patients, and ECG should be done because sometimes myocardial infarct can be a precipitating factor, and we should do infection screen. As I mentioned, that sepsis is a very common precipitating factor for this hyperglycemic emergencies. So we have to correct the potassium deficit. So depending upon the initial potassium, we should give potassium to correct potassium deficit only when the potassium level is less than 5 and we have a reasonable urine output. Because sometimes in patients with diabetic ketoacidosis and renal insufficiency, they might have a severe hyperkalemia initially. But once we start them on insulin and hydration, the potassium precipitously drops. So even with a potassium level of 5, say for example, we have to give them potassium because we know it's going to become 2 in 24 hours. If the initial potassium is less than 3.3, that means there is a huge potassium loss in this patient, and this patient should get potassium first and then replace insulin. The reason is, if you start insulin without giving potassium, the potassium will enter the cells and there will be a severe catastrophic hypokalemia. The potassium has to be replaced at the rate of 20 to 30 cc millimoles per hour. Now, phosphate deficit is another big problem in DKA and HHK, and nowadays potassium phosphate infusions are available. So, we should be replacing phosphate along with potassium. The best replacement fluid is K-phos in these patients. Magnesium is another electrolyte which is deficient. So, along with deficiency of hypokalemia, magnesium deficiency should also be corrected early in the course of DKA. What's the role of bicarb in diabetic ketoacidosis? By and large, acidosis is well tolerated in these patients, so bicarbonates are not routinely given. If a patient is severely acidotic, severely hyperkalemic, refractory hypotension with metabolic acidosis, bicarbs can be given in these patients. So, but in severe acidotic patients like pH of less than 6.9, bicarbs are usually given, but not many studies have been done on these, and one should not try to normalize pH, and the bicarb infusion has to be given 100 milliequivalent over 4 hours and no bolus. Now, insulin infusion in diabetic emergencies needs to be given, and initially a loading dose in order to get to the receptors, 0.15 units per kg of regular insulin is given, followed by an infusion which can vary between 5 to 10 units. As I showed you the insulin dynamic scale, one can pick up the scale at which the insulin infusion has to be started depending upon the first blood sugar. Doubling the infusion dose if glucose does not decrease by 10% or 50 to 70 milligram in first hour. So, one has to keep a close eye on the glucose value and keep on increasing the insulin infusion dose if the sugars do not come down, and initially measure the blood sugars every hour. Once the blood glucose level reaches 250, then we should decrease the insulin infusion to 0.5 units per kg per hour, so around 3 to 5 units per hour. We should not stop insulin infusion even if the blood sugar comes to normal level, otherwise they will rebound to severe hyperglycemia, and if necessary we should start feeding the patient or even give some glucose, but continue the insulin infusion. And we should target blood glucose reduction to slower reduction of less than 50 milligram per hour. What are the conditions when we stop insulin infusion in DKA patient? Once the acidosis is gone, there is no ketonemia. By and large, we don't measure blood ketones. Urinary ketones are not very useful tool. So, there should not be much acidosis. If the anion gaps are getting better, nowadays we calculate delta anion gap, which is being talked about in ABG lecture. The glucose is under control and the hemodynamics of the patient is stable and the dehydration is corrected. Insulin use in hyperosmolar state, once the dehydration is corrected with intravenous fluid, that itself corrects the glucose abnormality to a large extent, and very high dose of insulin infusion is usually not needed, and lower dose usually suffices in these patients. And usually a higher blood glucose levels are maintained in these patients of around 300 milligram, and one needs to calculate the osmolality and aim for an osmolality of less than 315. Usually these patients are very drowsy when they come in, almost mimicking a stroke. So, improvement of mental status is also a guide, and we should decrease the insulin infusion and keep the glucose around 300 milligram per dl, and because we do not want a rapid shift in osmolality. Again, when these patients get better, both the DKA and HHK patient, we need to switch to subcutaneous insulin. This can be given as an overlap insulin. We can give long acting once daily and intermediate or short acting insulins before meals, and there has to be an overlap between subcutaneous insulin and IV insulin. So, first the subcutaneous insulin is given and IV infusion is continued for 2 hours, and type 2 diabetics need insulin for several weeks after that, and they might go back to their original regime. We should never forget to correct and identify and correct the precipitating factors which cause the DKA. Usually it could be a sepsis, it could be a myocardial infarction, it could be a pancreatitis, it could be a stroke. So, giving details, having details of this and managing these problems will go a long way in managing this patient as a whole. Thank you for your kind attention.